We have the best staff survey results in the NHS. The model hospital data shows us to be the most efficient acute trust in England, and we are part of an emerging integrated care organisation in Dorset, and recently secured an agreement to fund 147 million of capital investment to change the role of this hospital in Poole Hospital, with this becoming the main emergency site for East Dorset and Poole, the main planned site. So it's been quite a journey. This first slide just gives you some context for the trust and our surroundings. We're a medium-sized trust of circa 300 million in terms of spend, just over 4,000 staff, and a busy emergency hospital. One of the significant factors in terms of our challenges is we've got the highest proportion of people living locally over the age of 85 in England, and that brings a whole range of challenges in terms of managing the frail elderly with lots of comorbidities and often people living alone. So let me take you into our journey, which really started in 2014 when we decided to put in place a comprehensive approach to quality improvement, and we decided to use Deming's approach, which many of you will be familiar with, of using PDSA cycles as a way of improving services. It quickly became apparent that in terms of the improvements we were starting to leverage through our QI methodology, it wasn't going to be possible to optimize where we needed to get to unless we started to address and change the culture in the organization as well. And therefore, and I'll say more about this in a second, we have taken a very bespoke approach to cultural change in the organization and put a particular emphasis on compassionate leadership. And we've used the work of Professor Michael West as a means of taking us forward. That's resulted in a significant heightening of staff engagement, and as I'll show you shortly, we won the Health Service Journal Award last year for staff engagement. As importantly, though, it has helped us improve considerably a number of our services to reduce our mortality levels, and we've got some outstanding feedback from patients along the way. So if we just start with the work that we have done on culture, in 2015, we employed a lady called Nicola Hartley. Nicola was previously the Director of Leadership for the King's Fund. And Nicola came into the organisation, and we agreed as a board that we would adopt a particular methodology in terms of our cultural change. And this took us over a 3-year life cycle, the first part of which was a discovery phase, where for 6 months we went out into the organisation and sought the views of over 1,200 staff as to both how it felt to work and care for patients in the organisation, but also to elicit their views on the type of culture they wanted the organisation to be about and the behaviours that they wanted people to demonstrate. The board at the time had an uncomfortable report, which were the views of staff in terms of how it felt and what they wanted to create. But it was quite clear at the outset that the only way forward was a very positive response and engagement from the board in shaping and helping nurture the type of culture. One of the important facets of this is that we appointed a range of what we call change champions. So these were people working in all facets of the trust who had dedicated time to talk to other staff groups to find out how it did feel to work and care for patients in the organisation, and to talk about what change was actually required. And as part of the contract we had with those individuals, all of whom were appointed, and we had many more applicants than we were able to appoint, we also had a contract with regard to their own personal development. So these individuals ranged from porters, cleaners, healthcare assistants, through to nurses, through to consultants. We had a a real cross-section of the organization. And they've taken us through 2 further phases to help us design how we support leaders in the organization and staff more generally, and also into the delivery phase of our leadership and cultural change program. As I said, that culminated last year in the team winning the Health Service Journal Award for staff engagement. More importantly, what it has done is change fundamentally how it feels to work in the organization. And we've seen the benefits of that in terms of improved patient care. We've also seen the benefits of that in terms of an ability to recruit and retain staff. And although we, like you, face some national pressures, they're not as great as they could be, partly because of the work that we have done in a whole range of areas. Some examples there: we've established Aston Team of Coaching. We've got over 30 trained coaches working with teams. We've established programs for staff having difficult conversations and to support staff in terms of their own personal resilience. We've also utilised work done elsewhere. In particular, we've worked closely with our neighbours in Frimley and taken their customer training programme and adapted it for our own purposes, and now all staff are trained in terms of customer training. These are some of the other steps that we have taken. So each September, and we're in the middle of it now, across the whole week, we run a program for leadership development and a Valuing You Week. So this year, as an example, we had Peter Homer from the Leadership Academy talking to leaders on Monday about his reflections on leadership in terms of his 37 years of working in the NHS. We also had a lady called Hayley Barnard, who has spoken to staff about diversity and inclusion, but in particular has extensive experience in unconscious bias and how this plays a part for all of us in terms of working together with other colleagues in the workplace. We try and reach out to as many of our staff as possible. So last year there were well over 1,000 that were able to attend. This year there'll be close to 2,000 staff that will be touched by various activities throughout the week. One of the things that we've changed in the organisation, we said to staff, how do you feel it would be appropriate for us to express our appreciation and value and say thanks? And we used to run an Oscar-type ceremony where we would invite 200 to 250 people each year to an event for particular awards. The feedback that we had is that that felt pretty exclusive, and often the same people went each time. And what we would prefer is a much more visible approach from the executive team and the board as a whole to recognising the contributions people have made. And we now run something called #ThankYou, where there is an opportunity for anybody working in the organisation to express their appreciation and thanks to colleagues for what they have done. We have an opportunity to bring that together in a marquee, as we are this year, and there'll be over 1,500 staff this year who are able to play a part in either being thanked or to recognising the work that others have done. So a very significant shift. It's small, but it makes a big difference. And the bottom line is people feel far more appreciated than they once did, and it's a much more accessible and equal process than it once was. There are just some pictures here of how people experience that day. The overall message, though, is it really is appreciated, and it's heightened people's appetite for saying, what makes you proud to work in the Royal Bournemouth and Christchurch hospitals? Something else that we did is we asked our change champions to work with the staff to develop the organisation's objectives. As I guess with many organisations, the board each year used to go through a process of setting organisational objectives, and often those objectives ran to 2 to 3 pages. And the reality, of course, is that they connected with very, very few people outside of the boardroom, and even within the boardroom, they didn't necessarily connect. So the staff themselves have developed these 4 objectives built around the themes of valuing staff, quality improvement, strengthening teamwork, and listening to patients. And every member of the trust has their own objectives set around these 4 objectives. So there are no other objectives, and whatever you do, wherever you work, your objectives are built around these themes, and these themes reflect our values, and the staff themselves have established the values that we all see as important within the organization. And this feels fundamentally different, and our appraisal rates are up over 90%. So we've made a lot of progress in that area. I just want to take you on to our approach to continuous improvement. So we've now trained over 350 staff in QI methodologies, and although we've got some central programs running in the trust and a team that supports that work, we've got countless different projects in Christchurch Hospital. Just in the day hospital alone over the last year, the staff ran over 150 different projects. What's important here is that we've got a whole range of staff, particularly clinical staff, now trained in QI methodology, so understanding how you use PDSA cycles, how you use measurement to drive change. And for me, one of the most significant ways in which this change is embedded is where I've sat down with really quite long-established consultants who in many ways would be viewed as quite cynical, and when they interview their prospective colleagues, one of the first questions they ask them is, what QI projects would you want to undertake within the trust? So it signals the progress that we have made. This particular slide captures some of the work that we've done with the Wessex School of Quality Improvement. We work with the Health Foundation, and specifically, we've created the capacity for registrars to have a year where they could focus exclusively on working with teams around QI methodologies. So we've seen some significant improvements in terms of how we care for older people, for example, and the input into older people services where those patients are undergoing surgery as a result of registrars working exclusively on QI projects. That's something that we have jointly funded, but has been really popular. As a result of the progress we've made, we've also made fairly extensive use of international conferences. So this year, for example, we had a dozen staff who attended the program in Amsterdam, all of whom were presenting their own particular projects. And it creates its own virtuous circle in terms of individuals supporting this work. Each year, as part of our Valuing You Week, a day specifically is focused on quality improvements and patient safety. Have a whole range of posters, but we have teams come and present, and we've had some really powerful presentations. We've had very experienced consultants, orthopedic surgeons, talking to 300 staff about how it felt when something went wrong in terms of use of the safety checklist, what that made them feel, and the learning that has come from that. We've also had other stories from teams who've gone through really quite significant emotional journeys in terms of improving services, dealt with some really difficult issues, and faced up to the wider audience about some of the challenges and some of the inadequacies within their own service. And it takes quite a brave step to be able to do that. The thing that I would reflect back to you is the culture within the organization has changed sufficiently that people feel willing and able to do that. And that's made an enormous difference in terms of the authenticity of the conversations we have, and a real sense that we're all working in the same direction to improve care. We test out on a very, very regular basis how people view our continuous improvement work. This is some work from one of our Schwartz rounds, just seeking views around a whole range of things. And we spend a lot of time gaining feedback and then playing back, this is what people said, this is what you told us, and this is what we've done as a consequence. What do our patients say? Well, you can see from this that there is a building picture of patients having a positive view of the trust. These are some results from our patient survey in relation to cancer, and you can see the trust zone result in terms of standing above the average and not scoring negatively, and that reflects across many of our services. If we take the view from our staff, so this is the staff survey for 2016-17, which shows the trust at the time to have the second best staff survey results, and much of this is associated with our work around culture and behaviours. That progressed into the latest staff survey results, where we moved from second to first place, and really very proud of that. You get some sense of the shift in terms of staff recommending the trust as a place to work, and also a place to be cared for as well. Now, we still have some dark spots, and when we get the staff survey results, one of the things that we do is dip into them in very, very specific detail, and a lot of focus on how we can support areas where there are still challenges, where it doesn't reflect what we would want in terms of how it feels to work in that area. Some very honest conversations around what we can do to support teams. Sometimes it's about coaching, but there are other ways in which we can also support individuals. Also, a big focus going forward this year on two things, one of which is heightening further medical engagement. We've still got further work to do in that. And the second is how we deal with poor behaviour as well, and in particular poor behaviour from senior individuals in the organisation who are generally seen to be making a good contribution, and therefore that behaviour is tolerated. And we've got more to do in terms of creating a sense that people are appropriately addressing poor behaviour. This is some information around those staff survey results and the difference from one year to the next. The one aspect that I'm particularly proud of is of the 88 questions, the trust came out significantly better than the average on 76 of those. So it's an indicator of progress. So it feels quite different to how we work in the organisation. If we think about the impact that our QI approach and the cultural work has had, there's some information on this slide just showing the shift in terms of both the SHMI and the mortality indices, and you can see that coming down, and you can see the mortality figures for the Royal Bournemouth and Christchurch Hospital from this latest data down to 88. Things haven't changed much since then. For Christchurch Hospital, the only inpatient facilities we have is for a palliative care unit. So the data is slightly different for Christchurch, but the reality is that all of our patients who are admitted at Christchurch Hospital ultimately pass away. This just takes you into some information that we have where we have charted our progress around patient indicators in terms of falls and acquired pressure ulcers. What you can see is sometimes it's taken quite a time to actually get the shift, and we've been cognizant of that. We've done a lot around how we've adapted our process to learning, but ultimately that has had the dividend that we wanted to, and a particular focus within the organisation on improving patient experience from hospital-acquired pressure ulcers and reducing the number of serious incident falls.
So, Tony, apologies, Danny, sorry to interrupt. We just had a question through, which I didn't know if now was a good time just to quickly chip in with a question, if that's okay.
Yep.
The question just was around what was your trust response rate to your last staff survey?
So the trust staff survey response rate was about 46%, so just under 1 in 2 staff responding.
Oh, brilliant, brilliant, thank you.
Okay. Just to indicate that our QI approach has thought to reach right across the trust, and whilst we focused on particular areas, and I'll show you one or two examples of those, it's about trying to maintain performance in a whole range of areas. So you can see some of the data around 18-week performance here, and again, our performance on the whole is significantly better than the regional or national average. This is quite interesting because often when we talk to colleagues from other organisations, one of the areas that is most difficult is getting people to complete mandatory training. The approach that we have taken is this is a fundamental part of everybody's appraisal, and that we need to use technology as a way of actually trying to assist in the process of mandatory training. And you can see some of the levels of attainment with it being around 94%. So a lot of good work in this area. This is some data drawn from the model hospital data. So this is directly from NHSI, and this is the most recent information that we have, that if you look at it from the perspective of cost per workforce adjusted unit, it shows us to be the second most efficient trust in the country and the most efficient acute trust. The trust that is first provides both community and acute services. Interestingly, much of Dorset features either in the top quartile or the top 50%. I wanted just to get into stroke. So what we have done is a lot of work across our health economy. We've used our own QI methodology to ensure that our stroke service is now, from a SNAP audit point of view, sustaining a level A rating. We've worked with our neighbouring trusts to shift their ratings from a C and D rating so that they're similarly now working at a level A rating. We're currently working to bring our stroke services together and to rationalise aspects of our stroke service, not just in the east of Dorset between Bournemouth and Poole, but across the whole of Dorset, involving colleagues also from Dorset County Hospital. Hospital flow has probably been one of the most significant areas that we've worked on, and we've worked over a number of years to improve performance here. So for our elderly care patients, we've dramatically reduced the length of stay, and when we've compared ourselves with neighbouring organisations, at times there's been a 3- or 4-fold difference in terms of length of stay for elderly patients. So we've used a lot of the recommendations and guidance that's come out from ESIP. We have focused on having quality improvement and action, what we call action learning weeks, where the executive team, including myself, sponsor activities and work with teams on a daily basis over the whole of the week to try different approaches through PDSA cycles and look at what changes can we make that work, and to also highlight those changes that we wanted to make which didn't seem to have an impact. So we had a week recently and we ran 43 different PDSA cycles over the week, focused in on improving flow within the hospital. One of the things that I think we do extremely well is support this with a lot of analytical support, so that the data we can cut in a whole range of different ways. So rather than necessarily just focusing on some of the areas of activity here, you can see the type of data that staff get in individual teams and the importance of looking at that on a trend basis. Much of it is also, though, about ensuring that we properly recognise the efforts of others. So we've just run a review in our emergency department, and we know many of our problems are those associated with the service outside of ours, where at times it can get very close to falling over. So we ran an action learning week from Friday evening through till Monday morning, and we had upwards of 70 volunteers that came in for specific shifts over that period so that we could review the process with the team in ED over the whole of that time period. And we then started to theme that in terms of key actions that we feel are appropriate to improve our particular processes. You can just see here some feedback from one of the teams in terms of their reflections on one of our action learning weeks. Again, just some further feedback from some of the nursing staff. These are members of our ED department. So the focus is very much trying to shift, and we're making good progress. We've still got further to do. People naturally associate with their own particular team and are very proud of their team. Where we were trying to get in terms of our wider culture was being proud of what we say as RBCH, the Royal Bournemouth and Christchurch Hospitals, and we're clearly moving in that direction. And teamwork is a big ongoing area of priority for us. These are some reflections from staff in terms of how it's felt as we've come together and worked over the winter period. So, for example, we have at times stopped providing services at Christchurch Hospital, moved staff across to Bournemouth, and there's been a real appreciation of how it's felt in terms of staff working in hard-pressed areas where we have had to reduce the amount of elective surgery, so staff have come out of theatres and worked in the wards. But you get a real sense that there is a collegiate team approach at the Royal Bournemouth and Christchurch Hospitals. We also use patient stories because the reality, and you know this better than I do, is no matter how much you focus on processes and individual methodologies, often what captures people is the story from the heart, and we've used individual patient journeys as a way of illustrating the benefits that come from particular change. For the gentleman you see in the bottom right-hand corner of this slide is a gentleman that spent a long time with us, and we talked through with staff, and he talked through with staff his particular journey, how it felt at times, having experiencing difficulty in being discharged from hospital. The other thing that we focused in on, which is slightly more unusual, is that we've taken the view that although there are issues in terms of the responsiveness of social services at times, or our CCG colleagues in terms of CHC applications and so on and so forth, the people that can impact most on reducing the number of people who are medically fit but can't leave hospital are those actually working in the acute hospital. And there was some really quite compelling work done by one of our medical registrars who said that probably 65% of the impact and responsibility still sits within the organisation. And she's led a piece of work that has demonstrated a very significant reduction to just under 6 days in the average length of stay for 2 of our elderly care wards, as a result of focusing in on the things that we can directly influence as opposed to the things that others can directly influence. This is some information around our patient flow. What I wanted to convey here is the work that we do to look at things that are statistically significant and really get underneath the data and understand the impact of the changes that we're seeking to make. So we have invested heavily in terms of our capability with data. It has made a real difference, and it's one of the ways where we have been able to draw in senior clinicians who've worked with this data and valued the ability to have timely information played back to them. Some further information just around average length of stay, and you can see again in the bottom right-hand corner the impact that some of our work has had in terms of reductions in length of stay. Also, and this is obvious, but it's important, it's not just about length of stay, but it's about getting patients in the right clinical areas of the trust, and we've done a lot of work around reducing outliers, and that's made a significant difference. And once you are able to do this, as you know, then so it's easier to manage the hospital. Interestingly, through this summer period, where generally we have been under intense pressure, I can't remember another situation like it. So there have been a number of days where we've had just over 100 empty beds. And that probably captures for me the progress we've made. And if I were to look back 3 or 4 years over the summer, we might have 20 or 30 empty beds, but we've regularly arrived at Sunday evening with upwards of 80 beds, despite the fact that Bournemouth is a big holiday destination, and this year has been particularly busy. And that underscores really the progress that our QI work has made, the impact that it's had. We've also focused on particular areas. This is a good example where our QI team worked with colleagues in endoscopy. We had a real struggle both with the numbers of patients exceeding the 6-week standard. The work that we did demonstrated that there were 47 different access points to our waiting list in endoscopy. Through the work that we've done in terms of QI, we've been able to radically re-engineer that pathway, and you can see that the impact that's had in terms of no patients waiting longer than 6 weeks. This is some work that, again, is really proud of. This is the changes we've made for patients experiencing emergency laparotomy. As you'll know, that the mortality rate nationally ranges anything between 5 and 25%. We've added no additional resource, but we've had a team led by one of our anaesthetists that's looked at how we deliver that emergency laparotomy service. We've changed it based on our QI assessment and methodology, and we've seen a significant reduction in mortality as a consequence. Big focus also on our deteriorating patients and reducing the number of patients who are musing at 9, but also ensuring that there is very, very timely intervention for those patients as well. And this slide simply shows the impact of one PDS cycle on another, and then another, and the reduction in terms of time it's taking to get a senior clinician to assess and treat that patient once they've deteriorated. Sepsis has been another area. This is a busy slide, as some of the others are. The message to take away from this, and we've worked on sepsis now for about 3 years, and it's been a real struggle at times, but we've got to about 72% of patients now receiving antibiotics within an hour, and we're starting to maintain that. So things are moving, again, there in the right direction. I just move us through surgical productivity. So we focus very, very specifically on areas where we want to improve care and outcomes. We've also recognized, though, that there are some direct productivity benefits. So this is some work done within theatres where, with the same staffing levels, we've been able to do 1,300 more operations than the previous year. Perhaps some of the most compelling information around our theatres is that we've not used any agency staff in over 2 years. And that says much about the approach we've taken to culture, to behaviours, and getting the right culture within our theatre service. So some really significant improvements there. Again, this is just a slide showing how we look at surgical productivity and understand some of the peaks and troughs, and once we understand those effectively, how we can improve productivity overall. Some further data. This really conveys the information I was just providing to you in terms of agency spend, and you can see the way it has dropped to 0 and has been maintained at that point. Phenomenal achievement by the team really in theatres. In terms of orthopaedics, we provide the 7th largest elective orthopaedic service in England. Big focus on reducing length of stay, doing a lot in advance with patients so that they're able to mobilise very quickly, and using our QI methodology really to improve productivity. And you can see some of the changes here. Length of stay reducing, more patients through our theatres, lower waiting times. This is a slide that really focuses on some of the work that we're doing going forward. So in amongst all of this change, we've also over the last 2.5 years been through an extensive consultation led by our clinical commissioning group who have now agreed plans to fundamentally change, as I said at the outset, the role of this hospital and Poole Hospital as well. We found that some of the approach we've taken to culture and QI has been really helpful in terms of the heightened level of engagement